Bismillahir Rahmanir Rahim. Assalamu alaikum. Good morning, everybody. First of all, I would like to welcome you in our 21st annual neonatology meetings, day 2. I would like to congratulate you and all of us for the winning of our Saudi soccer. Alhamdulillah, it was an achievement. Inshallah, kaman. The World Cup, inshallah, يكون من نصيب المنتخب. So, without our further delay, there will be some modification in the program. So we'll start the second session, which is the neonatology quality improvement initiatives in the morning, and then the first session will be in the second one. So, without any further delay, the NICU quality improvement is very important topics, and it has a very measurable outcome in the care of the neonatal ICUs. I have really a word. Maybe I remember it, and I would like everybody to remember it. So, NICU without quality, like اللي يصوم وما يصلي. So it's really important. It's not only how to take care of the baby, just the quality of care you give it to that baby. So our first speaker is Dr. Nisreen Al-Kafi. Dr. Nisreen is a consultant neonatologist at King Fahd Armed Force Hospital, and she is the head section of the NICU. She will talk to us about the NICU quality improvement initiative in the NICU. Dr. Nisreen.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Jabara, for the introduction, and I would like to thank the organizing committee for the invitation and give me the chance to present today about the quality improvement initiative in the NICU and the effect of the quality in the NICU outcome. First, I have nothing to disclose, and here is my talk objective, concept of quality improvement in the neonatal care, understand the variation in the extreme preterm infant survival and morbidity worldwide, why do we need to collect data, and where we are, what are the most important domains in the quality improvement of NICU, and what are the evidence of quality improvement initiative that having a positive effect on NICU outcome. Let's start with a bit of history, because we cannot talk about the quality improvement without acknowledging the guru in this field, starting from the Walter Shewhart. He's the one who developed the statistical process and run chart. In the extreme right, Edward Deming. He's the one who introduced the concept of quality improvement from the industry into the healthcare. And Don Berwick, he is a pediatrician from the Boston, and he is one of the leaders in the quality improvement. As well, Professor Paul Batalden, he is from UK, and he has many contributions in the quality and patient safety. In the bottom of the slide, you can see a statement that's come from those leaders that pop up always in different slides, time again. Every system is perfectly designed to get the result it gets. We need to try or to work to improve, otherwise we'll not get the result change, and we'll get the same result, and things not will be changed. What is quality improvement in the healthcare? There is many definitions about the quality improvement. I find this one the simplest one. It is a systematic, data-guided activity designed to bring immediate improvement in healthcare delivery in particular setting. Everyone comes to work and would like to see an improvement. So it is a deliberate, defined process which is focused on activity that are responsive to the local needs and improve health. It has to be continuous. It has to be an ongoing effort to improve. But at the same time, it should be result in a measurable improvement in the efficiency or effectiveness or performance or accountability or equity, and ultimately good outcome. Everyone thinks about the quality improvement, and there is a lot of idea come across the mind once we think about it. And different question also will rise. How to begin? How to start? Where to start? There is many articles done by different people can help to initiate and to guide in the process of the quality improvement. Why do we need to improve quality? It's very important to see that the science progress so fast and the patient care does not follow. And here is the quality gap. There is pointer? Okay. And here is the quality gap that we need to fill and working toward move this curve toward the science. But as well, doesn't mean that we need to adapt every randomized control trial. We need to know what's the best to our center and try to do it and achieve it. What happened from 1970 to 2020 in the neonatal care? In 1970, we started the ventilation, CPAP. In 1980, we got the steroid. 1990, we started the surfactant. And in 2000, nitric oxide and ECMO. After that, since that, we are trying to apply what we know gently, avoid mechanical ventilation, integrate family into the care. And in the last decade, how to do it better, what we know, and how we can do it in consistent. There is humble of randomized trial in the neonatal care, but in the last 10 years, what we are doing is applying what we know to the clinical setting gently, and this is an quality improvement. Although there is always an effort to provide the best care, but still it is unclear how often we achieve this goal. Current literature demonstrates that there is a variation in the outcome and survival mainly of the extreme preterm infants. And they did this study over the 10 years, comparing the survival rate of extreme preterm infants, 29 weeks and less, in 10 different international networks. 10 countries involved, 10 international networks collaborate with the INO, the International Network for Improving Outcome of Neonates. And they compared the result over the 10 years. And as we can see, those variation. And here was the result. The Japanese neonatal network has a great survival, around 83% of extreme preterm infants. And in the Israel, around 35%. Spain is around 36%. And there is a huge, this is a very huge difference, and as well it affects the total of the average of the international network survival. And this study, the key points from this study, that the survival and the morbidity were significantly high, the variation. And this variation was reduced over the period within a Canadian neonatal network. And over the 10 years period, some other networks, they have the same variation and they didn't change anything in the variation and in the outcome. It is very important to know where the reason of there is no improvement of the outcome and the variability, and what's the causes of this variation. At the level of the organization system and the manager, improving extreme preterm outcome require concerted effort from clinician, manager, policymakers, and admin. Identification of facilitator and barrier to the system level that for the adverse outcome of the neonates is needed to meet the overall goal of improvement of the outcome and quality of care of neonates. It is nice to see some Saudi data, neonatal data from different single best centers. Here, Al-Qurash Italy, he showed the survival rate of the extreme preterm infants according to the gestational age. And Abu al-Fatuh Italy, he showed the mortality rate according to the gestational age as well to the birth weight. Al-Hazan Italy as well, he showed the survival rate according to the gestational age and compared with the international neonatal network. Al-Turqawi Italy as well, he showed the survival rate according to the gestational age in 2 different periods. Here is unpublished data in my center, the survival rate of extreme preterm infants less than 30 weeks. And still, with all these studies, we are seeing even in the neonatals different Saudi centers, there is a variation in the outcome and as well in the survival. And I believe that the collaboration between centers at different level is a key feature for many system or network that aiming for improve the quality, safety, and outcome in the NICU. Because the principle behind the collaboration is the benchmarking, sharing knowledge, and as well the promoting evidence-based practice. And hope we can see this collaboration to improve and to learn from each other. For the quality improvement initiative, I will use the Canadian Neonatal Network as an example because they have a very nice and beautiful journey over years. It was in phases. They initially they collect the data from different centers of the Canadian Neonatal Network, and they found there is a variation in the outcome between the Canadian center at the national level and the international level. So they implement the EPIC program, which stands for Evidence-Based Practice for Improving Quality. And this program was it's an evidence-based with the targeting intervention on variation of outcome with the collaboration of all Canadian centers and the expertise leading this program. And as well aiming for creating a culture of continuous improvement. So they have the phase 1. The phase 1, they involve only 12 centers of Canadian center. 6 centers, they was concentrated on the bronchopulmonary dysplasia, and the other center was concentrated to improve the outcome on the hospital-acquired infection. And after they saw the reduction in the morbidity and improvement in outcome, they launched the phase 2, which is this published in this study, the Association of Quality Improvement Program with Neonatal Outcome in Extreme Preterm Infants. It was the phase 2 over 3 years, and they targeting the survival as well 5 major domains, the IVH, bronchopulmonary dysplasia, NEC, hospital-acquired infection, and ROP. And they found reduction after implementing the EPIC program, generalized to all neonatal Canadian in ICU, they found a reduction in the odd from the baseline to year 3, as we saw in the last column, the reduction around 37%, and they found the most of the improvement was in the group between 26 and 28 weeks. With a little improvement, and there is an area to work more in the group between 22 and 25 weeks. After the success in the phase 2, they started the phase 3, and the aim was to see how this program, the EPIC program, is sustainable. And they did this study over 5 years. After they finished, they found there is still improve in the survival to discharge without major morbidity, and the program was very sustainable, and the result was sustainable. Sustainability is difficult and challenging to maintain the result, and they are able to do it. Quality improvement is a continuous process, and here is another Canadian study. They saw the outcome of the preterm infants less than 33 weeks over 14 years after implementing the EPIC program. And they found the results from survival to discharge without major morbidity. They have 4 groups according to the gestational age. The result was very impressive. That's the improving was going toward, and it was sustainable over the 14 years. So they conclude that the EPIC program has an increase in the survival and decrease in morbidity. And the key lesson, patient outcome can be improved by doing better with what we know. And this is another big initiative from the Pediatrics Collaborative from US. Usually in the quality improvement, they are targeting one outcome, but in this study, they aimed to target many domains and morbidities. The purpose was to initiate large-scale stimulants in multiple domains of care in large neonatal network. And they target multiple processes and outcomes that were thought to be a key driver of morbidity and mortality in the NICU. And the key driver was chosen based on the literature: nutrition, medication, central line care, respiratory care, delivery room care. And they used the SMART aim, and they start to do the process of the changes. And they adapt the quarter 8-step model of changes. It is a process to help leaders in changing implement the changes. And it's focused on creating the urgency in order to make the change. As well, the process it takes through the initiating, managing, sustaining through the 8 steps. And the result was there was a significant improvement in the survival and in some of the domains of the morbidities. And I would like to pay an attention about one of the important factors to facilitate the quality improvement projects is the work environment. This study was done to investigate the association between the work environment and the quality of care, safety, and patient outcome. They found the improving in the work environment may be promising strategy to achieve better and safer practice, especially for the nurses, the nurse quality report, and the NICU relevant outcome related to infection and patient readiness to discharge. As well, one of the things that can help in the quality improvement, the culture of the organization. The organization culture, they found it improved the patient outcome and decreased the mortality in neonatal intensive care and higher performance on safety. And in this study, they found the higher hierarchy culture score was associated with higher survival without major morbidity. Just to mention some of the quality improvement projects initiative in the, my center, and would like to highlight that the data is very important. You need first to have your data and to see where is your unit, and then translate this data into the information and compare it to other centers as well to the other network. You cannot manage what you don't measure. Start simple and get your team. And then in this initiative, we use the model for improvement, and it has an aim, measure of change. And there is tools to assess the changes in the quality improvement. We use the BDS cycle. And the rate of the ROP was significantly high in our centers in 2015, and we had all the process, and we are able to get down to 5%. As well, we found a problem with the hypothermia and extreme preterm infants on the admission, and we start the quality improvement, and we decrease it to 2% in 2021. Hospital-acquired infection start to decrease. Still, we didn't reach the target, but still we are on the way of improvement, inshallah. Home message. Neonatal survival and sequelae of NICU graduate are variable worldwide. Collecting data is the first step, is a crucial step when starting any quality improvement project. Quality improvement projects matter and has a huge difference in the outcome of the NICU that no other scientific research has done. NICU teamwork and collaborative work environment are essential aspects of successful quality improvement. Quality initiative and neonatology service are applicable locally and improve the outcome and the NICU care. Thank you.
Thank you, Dr. Nisreen, for this excellent start. As I said, we'll keep the question at the end, but I reminder you, NICU without quality زي اللي يصوم وما يصلي. Okay, so it's very, very, really important. So we'll go to the second topic, will be retinopathy of prematurity. Retinopathy of prematurity will be presented by Dr. Maali. Dr. Maali Abdel Fattah. She's a consultant ophthalmologist and retinal surgeon and at King Faisal Specialist Hospital in Riyadh. Dr. Maali could not make it physically, so she will be as a virtual. So can we connect, please, Dr. Abdel Hakim?
Assalamu alaikum.
Alaikum assalam.
I am Dr. Maali from ophthalmology talking about the retinopathy of prematurity.
Dr. Maali, share your slide, please.
And I am trying to share my slide, but it appears for me a message host disabled participant screen sharing.
Can you make her the host, please? Okay.
Okay.
So you can now share your slides, please.
Yeah, I will try now. So now I am sharing my screen. So it's clear now or not yet?
Go ahead, Doctora.
Okay. So good morning, everyone. I am honored to be with you today in Saudi Neonatal Society conference. I will thank everyone for all this arrangement, and it will be a simple presentation about retinopathy of prematurity. So retinopathy of prematurity is a major causes of childhood visual disability, which is largely preventable. Many extremely preterm infants will develop some degree of ROP. Although in the majority of the cases, this never progresses beyond mild diseases, which resolves spontaneously without treatment. A small proportion develop potentially severe ROP, which can be detected through the retinal screening. If untreated, severe disease can result in a visual impairment, and consequently, all infants at risk of sight-threatening ROP should be screened. So we'll talk about a small figure showing the normal retinal vessel developments. Here in the figure in the left side, showing the normal retinal vessels when grow starting from the optic disc and going centrifugal toward the retinal periphery. This is the normal retinal vessel developments which normally developed in the utero. What happened if the baby or the infant born preterm as a result of the low oxygen tension in the utero? This is a main stimulus for the normal retinal vascular development, and this will be interrupted if the baby born premature. So the ROP pathogenesis develops in two phases. The first retinal phase, it consists of stoppage of the retinal vessels growth in the utero and regress. Why? Because of the high oxygen level, which it is necessary to maintain adequate level of circulating oxygen for the survival of the preterm infants, which inhibits retinal vascularization. And the phase 2 starts when the newborn grows and the metabolic requirements of the retina increase. The retina becomes more hypoxic, inducing a more compensatory, devastating, and apparent new vascularization. As you see here in the ROP phase 1, there is an interruption and regression of the normal retinal vessels developments. And here in ROP phase 2, starting the developments of new vascularization, which is derived as a result of decrease of the oxygen with resulting increase in the vascular endothelial growth factors and erythropoietin factor and the insulin growth factor. And those factors promote developments of retinal new vascularization. Again, this is another figure also showing the retinal developments, the normal retinal developments here in the utero with the normal level of insulin growth factor and the normal level of the vascular endothelial growth factor. If the baby
دكتورة معالي, we lost the sound.
factors.
دكتورة معالي, we cannot hear you.
Can I continue, Doctor?
Yeah, share your slide and continue, please.
Yeah, okay.
Okay, go ahead.
Yeah. So we reach here that there is a new retinal new vascularization which developed as a result of increase in the level of the insulin growth factors and the vascular endothelial growth factors. And that the baby can pass or the infants can pass in one of two ways. Either normal vessels growth in the retina with decreasing in the vascular endothelial growth factors and the complete resolution of retinopathy of prematurity. Or the other way is increase the vascular endothelial growth factors leading to a proliferative retinopathy and leading to a retinal detachment. So prematurity in a study done in 2019, retinopathy of prematurity, discussing the incidence and the risk factor of retinopathy of prematurity in a tertiary hospital, they found that there is a 38.6% of the infants have a retinopathy of prematurity. In another study also discussing or investigating the incidence of retinopathy of prematurity in a tertiary center in Jeddah, they found also that there is an incidence of retinopathy of prematurity which is Just 1 second, but I will answer my pager. Sorry for this interruption. So they found in Jati. In another center also done in Tabuk, they found that there is an incidence.
Dr. Maali, we lost the sound. Shakil, connection please. Go to the next your presentation. Dr. Khalid Davis.
لا ده الواي فاي اللي هو حاطط اوكي.
Doctora, due to connection problem, we will proceed with the next presentation.
So now it returned back or not yet?
Dr. Maali.
Yeah.
We will proceed with the next presentation because of the connection issue.
I am here. Is it okay?
Okay, go ahead.
Yes. So UK screening of retinopathy of prematurity, mentioning that published in March 2022, mentioning that all infants less than 31 weeks gestational age, up to and including 30 weeks and 6 days or less, then 1,501 gram birth weight should be examined to screen the presence of retinopathy of prematurity. What are the risk factors for retinopathy of prematurity? Low birth weight, low gestational age, or prolonged oxygen treatment, blood transfusion, and sepsis, or all are statistically significant risk factor for the development of ROP. When to examine a baby first time? For the infant born before 31 plus 0 weeks gestational age, the first ROP examination should be performed between 31 and 31 plus 6 weeks post-menstrual age, or at 4 completed weeks postnatal age 28 to 34 days or later. For the infant born from 31 weeks, the first ROP examination should be performed at 36 weeks post-menstrual age, or 4 completed weeks 28 to 34 days, whenever is sooner. And this is a very nice table showing exactly when to screen the baby for retinopathy of prematurity. Yani, for example, if I have a baby born at 24 weeks, so wait 7 weeks and start the screening at 31 weeks post-menstrual age. In preparation for the eye examination, as usual, as we are doing in the neonatal ICU, use a mydriatic combination of phenylephrine 2.5% and the cyclopentolate 0.5%, and still 1 drop of each drug in 3 doses, 5 minutes apart, and then 1 hour prior to the examination to achieve effective mydriasis in preparation for the ROP. We can use local anesthesia just prior to the examination when an eyelid speculum is to be used. Consider using a combination of care techniques to comfort the infants during the eye examination. For example, we can use a nesting or a swaddling or non-nutritive sucking or administration of expressed breast milk. Parents and the carers should be offered the opportunity to be present during examination and facilitated comfort care. Consideration during the examination, keep ROP screening as short as possible. For the examination undertaking as an outpatient, ensure appropriate neonatal resuscitation equipments and a health professional trained pediatric basic life support are available in the examination area. If the infants are unstable during an outpatient examination, a period of observation is necessary before discharging the infant home. Discuss with the parents and the carers the results of the screening, the next steps, and their baby may be unsettled after the examination. And here is the methods of examination of our baby in the neonatal ICU. What are the stages and the zones of the ROP? Here we have a retinal image showing stage 1, which is considered as a demarcation line between the avascular area of the retina and the normal vessels, normal retinal vessels. And here is a stage 2, which is showing elevated tuft separation between the avascular area and the vascular area. And the stage 3, it is considered as an elevated vascular tuft. And the stage 4, it is a development of subtotal retinal detachment. Stage 5 ROP, it is considered as a 3 sub-categorization in the form of 5A open funnel retinal detachment, 5B closed funnel retinal detachment, and 5C, which is a 5B plus anterior segmented changes like marked anterior chamber shadowing, iridocorneal lenticular adhesions, and the corneal opacification. And here are zones for retinopathy of prematurity. Zone 1, it is considered as a circle with the center over the optic disc, and the radius, it is considered as a double the distance between the optic disc and the macula. And then zone 2, it is considered as another circle with a boundary from zone 1 to oral nasal serrata in the nasal area up to the temporal quadrants in the temporal area in the equator. And then zone 3, it is considered as a sector, the remaining sector which is present between the periphery of zone 2 up to the oral serrata at the temporal area. This is a hand drawing to choose which clock hours. So we are talking about the right eye here for this baby, and his 12 clock hours is here, and then 6 clock hours is here, and then 3 clock hours is in the nasal of the the right eye, and then 9 o'clock in the temporal part of his right eye. And again, this is zone 1, which is twice the radius from the optic nerve to the fovea and with macular involvement. And this is another picture also showing the zones of the retina and clock hours also, including the right and the left eye. What about the plus disease? The plus disease is considered as an increased venous dilatation and arterial tortuosity of the posterior retinal vessels, which can increase in severity to include the iris vascular engorgement, poor pupillary dilatation, and the vitreous phase. Actually, plus disease for the ophthalmology is very essential because it determines the treatment. Shall we proceed for the treatment or no? And we'll discuss it in the treatment. And here is the plus disease, fundus photos showing the plus disease in the form of arterial tortuosity and venous dilation, which is considered as a plus disease. What about babies who developed aggressive posterior ROP? Risk factors for the aggressive ROP are extremely premature, birth weight less than 1 kilo, or gestational age less than or equal to 28 weeks, dysregulated oxygen supplementation, intrauterine growth retardation, sepsis, and thrombocytopenia. Characteristically, aggressive retinopathy of prematurity has a zone 1 or posterior zone 2 involvement with prominent plus disease, large vascular loops, and the flat extraretinal fibrovascular proliferation. This is denoting aggressive posterior retinopathy of prematurity. The international classification of retinopathy of prematurity 3, it determines that we cannot depend on only posterior, the name posterior, but if we see these changes present in zone 1 or zone 2, so we'll consider for the treatment. بس
Dr. Maali, we cannot hear you.
Yes, Assalamu alaikum. Did you hear me now?
Yes, now we can hear you.
Okay. So aggressive posterior retinopathy of premature disease is photos also showing stage 3 in zone 1 and posterior disease zone 1 or posterior zone 2 and the prominent plus disease, which is considered as an aggressive posterior retinopathy of prematurity. A pre-plus disease is defined as a vascular abnormalities of the posterior pole that are insufficient for the diagnosis of plus disease, but that demonstrate more arterial atrociosity or more venous dilatation than normal. What about type 1 ROP? It is a stage, zone 1, any stage ROP with plus disease, zone 1, stage 3 ROP without plus disease, or zone 2, stage 2 or 3 ROP with plus disease. Actually, it is very important because it will affect our, decide our further management. International classification of retinopathy of prematurity, also report 3, defines the presence of a notch may lead to a more posterior staging of the ROP. It describes it is an incursion of the ROP by the ROP lesion of 1 or 2 clock hours along the horizontal meridian into a more posterior zone than the remainder of the retinopathy. Here is a baby with a stage 3 ROP in zone 2, but he has this notch which it is incurred inside the zone 1. What about the telemedicine for the ROP? Actually, in 2006, American Academy of Ophthalmology survey found that only 54% of the retinal specialists and the pediatric ophthalmologists are not willing to manage an ROP. And over 20% plan to stop because of the concern such as poor reimbursement, logistic difficulty, and the medical legal liability. So what is the solution to screen those baby? They invent this wide field ophthalmic imaging camera, which captures all color images for the baby in the rural area especially. And then the images will be reflected to an expert who discuss the stages of the disease and further management either for a follow-up or for treatment. Also, artificial intelligence in the ROP take a very robust intelligent role in screening of the ROP and the detection of the severity of the ROP. As we see here, the images will be artificially interpreted, and then it will also determine which stage for the ROP. So we talk about the screening of the ROP, suitable time for the first examination, and the stages and the ROP and stages and the zones of ROP. What about the treatment of retinopathy of prematurity? Refer infant for treatment when criteria have been met. Zone 1 with plus disease and with any stage of the ROP, or zone 1 without plus disease but with a stage 3 ROP, or zone 2 with plus disease and with a stage 3 ROP. Zone 2, stage 2 with plus disease is borderline for the treatments, as we'll discuss later. So this is a very nice table also to choose to show us when exactly you can proceed for the treatment. Yani, for example, here if the baby has a type 1, any stage in zone 1 with plus disease, so we have to treat. If the baby has a type 1, stage 3, zone 1 without plus disease, so we have to treat. If the baby has a stage 2 or 3, but zone 2 with plus disease, so we have to treat. What about the subsequent examination for the ROP screening? After the first ROP screening, if the treatment is not required, re-examine at least weekly when the vessels end in zone 1 or posterior zone 2 with or without any stage of ROP, or if there is any plus or pre-plus disease, or if there is a stage 3 ROP in zone 2 or zone 3, until the criteria for the treatment or 2 weekly examination or termination have been reached. Type 1 to terminate the screening for the ROP. For the infant without ROP, continue examination until complete vascularization extending into zone 3. For the infant with any stage of ROP, consider discontinuing the screening examination when the following characteristics are detected: partial resolution progressing toward the complete resolution, or change in the color of the ridge from the salmon pink to white, or growth of the vessels through the demarcation line. And here is a very nice also algorithm for ophthalmic observation. Yani, for example, if I have a baby with ROP stage, there is no stage for the ROP, so we can observe a baby. But if the baby has stage 1 or 2, يبقى in this area we have to look for the plus disease. If there is a plus disease يبقى if there is no plus disease يبقى every 2 weeks. But if there is a pre-plus disease, it will be every week. But if there is no plus disease, it will be also every week, and will no need for the treatment now. What are the treatment options? In the past, they were using cryotherapy to treat a baby with ROP, and sometimes also it needs to paraplanar vitrectomy to treat the baby with retinal detachment. But nowadays, with the further ROP screening and with the program of the ROP screening, so no baby reaching to...
Dr. Maali, 3 minutes.
Okay, right. This is a machine which is used to deliver a laser treatment for the baby, which is called the diode indirect laser photocoagulation. And here is a fundus image showing a laser marks. But unfortunately, with the laser therapy, I found a lot of complications like macular dragging and high myopia. So they started to proceed for another line of treatment, which is an intravitreal injection of antivascular endothelial growth factors. And they started to develop multiple studies like bevacizumab eliminates the angiogenic threat of retinopathy of prematurity. They're conducting a prospective controlled randomized study to assess the intravitreal bevacizumab monotherapy for zone 1 or zone 2 posterior stage 3 versus conventional laser therapy. And they found that intravitreal bevacizumab, as compared with conventional laser therapy in the infant with stage 3, has a significant benefit for zone 1, but not in zone 2 disease. Another study, which is called the Rainbow study, and we were lucky in our center in King Faisal Specialist Hospital to perform this study and the chair in this Rainbow study, which is a 2 years outcome of another antivascular endothelial growth factor. It's called the ranibizumab versus laser treatment for the treatment of the very low birth weight infants. And they found that 80% of the infant achieved treatment success with ranibizumab 0.2 milligram versus 66.2% with laser treatment. Another study which is assessing the efficacy and the safety of intravitreal aflibercept compared to laser photocoagulation, and they found also that there is a great successful treatment with injection of aflibercept in the retinopathy of prematurity. So this is a study with a great results, and also our take-home messages as the telemedicine alleviates the burden of the ROP screening by implementing the remote interpretation of the digital fundus images by an ophthalmologist, and intravitreal antivascular endothelial growth factor became the promising treatment for ROP. However, the studies are now investigating the systemic absorption of those medication with the resulting systemic side effect like cardiac hypertrophy and pulmonary hypertension. Thank you so much for listening to me.
Thank you very much, Dr. Maali, for your presentation. We'll take the session at the end. We'll take the question at the end of the session. Thank you very much. So now it's my pleasure to present another important topic about the medication safety in the NICU. As we know, medication error is very common, and it's happened really in NICU more than 8 times more than adult wards. And the study has been reported that many medication error happen in the NICU is preventable. So it's my pleasure to introduce Dr. Khalid Tahir. Dr. Khalid Tahir is a pediatric clinical pharmacist at King Faisal Specialist Hospital in Riyadh, and he's a doctor of pharmacy to 2020 Western University of Health Science, Pomona, USA. And he will talk about medication safety in ICU. Dr. Khalid. I'll just put on one and this one, 2.
Thank you for the introduction. Assalamu alaikum. Good morning, everyone. Today I'll be talking about medication safety in pediatric floors, focusing in critical care pediatrics and NICU as well. Now I'm back from my scholarship for over a year practicing King Faisal in the pediatric intensive care unit. So nothing to disclose with regards to this activity. Upon completion of this topic, we should be able to achieve several objectives, including identifying areas for improvement to minimize medication errors in pediatrics, recognizing the reasons for medication errors, as we see maybe in daily practice, daily basis, some medication errors and challenges in treating those special population or vulnerable population, particularly the NICU patients. Indicating the factors that affecting the drug, pharmacokinetics principles like absorption, distribution, metabolism, and excretion for those patients, listing contraindicated drugs. We know there are some cutoff for using certain medications and what's the reason behind these cutoff for those patients. And also distinguishing specific dosing consideration for those population when we compare it to the adult population. I would like to start my talk with a question. So, thinking out loud, what do you think about when you compare it to adults about the rate of medication errors that might result in harm or death in pediatric patients in general? Do you think it's going to be 2.5 times less likely compared to adults, more likely compared to adults, or it's going to be almost similar? Maybe more likely, right? We have maybe seen some ADRs, medication errors, incident reports related to those population. Practicing in some institutions, you will get these reports or presented in some meetings showing several ADRs or medication errors happened for those populations. And the rate of medication errors resulting in harm and death for those patients, pediatrics versus adults, was reported as 31% in adults versus the 13% in peds. And imagine as many as 1 in 10 hospitalized children are impacted with those medication errors. And up to 35% of these errors are serious or life-threatening. And as introduced earlier, a lot of medication errors could be preventable. So this was a survey from the Institute of Safe Practice or Safe Medication Practice that published in 2015, online survey of pediatric medication safety that included 1,463 respondents, mostly pharmacists and physicians and nurses. And they were asked to select the frequency they employed, key error prevention strategies, and they published the part 1 summarizing findings and compared to similar survey completed in 2000. So these are the responses that got the least percentage as always or almost always. So we can consider those as areas for improvement. You think about them if we have implementing this in our institution or not. The first one would be prescribers including both dosing, weight-based or body surface area-based, like milligram per kg, in addition to the calculated total amount of the drug that might prevent medication error. Prescribers orders pediatric liquid meds in metric doses, like we do in mLs, milligrams, but not in ounces or pounds or other non-metric doses. Dose range check. Have you seen the DRC maybe in your electronic medical health system that you use in your institution? The dose range check software that's available enabled in the computerized physician or prescriber order entry that gives you the pop-up message alert when you order a medication for those patients if you are out of range, if you are underdosing or overdosing those patients. And this DRC list of medications are supposed to be reviewed by clinical pharmacists. Adults, pediatric, and unit meds are not stored near each other. This is mostly for pharmacy practice or medication rooms in the floor. The bedside barcoding scanning also, this is another automation solution. And involving clinical pharmacists by actively participating in patient care rounds and providing their input as well. All right, so we can summarize some reasons for the medication errors that we see in our daily practice, such as the pediatrics are at risk of harm due to the errors. Several reasons could be the size of those patients. Maybe you could imagine what was the smallest baby you've ever seen, right? I don't know, in Oklahoma, I have seen, doing my residency, like 0.45 grams, like less than half kilo. Maybe somebody saw less than that? Maybe, or closer to that weight, right? Again, could be challenging with dosing those population, right? Weight-based dosing, a lot of calculation compared to adults, not fixed dosing. Immature renal hepatic function that might affect or make an unpredictable absorption or unpredictable clearance of medications. Inability to communicate complaints and serious adverse drug events for those babies, especially like younger than 6 or 5 years old. And children are particularly vulnerable to errors if they are less than 2 years old. Right, so what about the challenges in treating peds in general, including the NICUs? Small fraction of all marketed drugs have any labeling pediatrics. You know, I think I remember one of the statistics previously published that maybe over 50–60% of medication you're using in the NICU or pediatric plus could be off-label use, right? Maybe submission, some hospitals call it Form B, or for submission of form for off-label medications. Like you can remember acetaminophen IV when it was marketed initially for over 2 years old. However, recently, now we're using it safely for neonates. Lack of information exposes children to risk, like lack of reported maybe ADRs or under overdosing references. Children denied new therapeutic advances. Like we sometimes go with what we have, old medications or old drugs available in the market because we don't have enough data and not published for the, not studied for those population. Challenges to measure, dispense, and administer, again, wide variety of sizes and dilutions. How many encountered, for example, small babies want to administer subcut medications like, for let's say, desmopressin, insulin, and the dose is beneath or less than what you can measure, and you have to dilute it, trying to find out dilution data, trying to extrapolate, ask for different institutions' practice to see if we can dilute these medications and administer. Need for calculation of individualized doses and lack of available pediatric formulations, dosage forms, and concentrations appropriate for administration, again, might be unmeasurable volumes to be administered. Oral drug concentrations is another issue in the market. You can see there are some medications that may have different drug concentrations, not only one. This is a problem mainly when we do sometimes medication reconciliation, taking medication history. The family won't tell us like how many milligrams. Most of the time they say how many ml they're giving their babies, right? Every dose, every day, and then we need to figure out what is the concentration of the medication and to try to calculate ratio proportion or do our quick math, find out how many milligrams, because our drug concentration in our institution might be different than what they purchase commercially or what they have at home. For example, here, like you can see, amoxicillin has 2 different concentrations. If they tell me they're taking 5 ml, I really can't tell without knowing the concentration, is it the 250 milligram or the 125 milligram? So would like to share this question with you for a KT is a 20-day-old girl, 4 kilogram, full term, came to the ED with cellulitis. The team wanted to start vancomycin empirically for this patient. What do you think the appropriate dosing strategy, knowing that the patient has normal kidney function? Would you go with the 15 milligram per kg, but what frequency? Is it once daily, Q12, Q8, or Q6 hours? Maybe by show of hands, who says A, once daily? All right. Q12 hours. All right. Q8 hours. Okay, see, now majority. And then Q6 hours, this. So I would agree with the Q8 hours. Again, each population, age group will have different frequency for some medications. That's based on, when you think about the clearance, the maturity of some of the organs, mainly the kidney, right? At birth, maybe it needs few months for the kidney to be matured, and then I can feel safe over 2 months, for example, 3 months, giving Q6 hours, again as a starting dose. We'll monitor and adjust, right? but as a starting dose. Now we correlate it back to the PK, to the absorption, distribution, metabolism, and excretion for those patients. This is a full 10 to 20 day, but if it's younger than that, I might go even to less frequent dosing, Q12, or if it's the patient became like 6 months, 8 months, maybe I feel safe to start with the Q6 hours dosing for those patients. All right, so we always say this, kids are not small adults. That's mainly because they're so different in some of the components when you compare it to adults, such as the drugs dosing. Again, it might be per dose, per kg, higher than the adult or lower sometimes, right? It depends on the drug. Like for example, if I give gentamicin for the neonate, usually for adults or for older kids, I just go with the conventional dosing 2.5 per kg Q8 hours. However, for those neonates, I might go 4 or 5 milligram per kg and give it once daily. So I'm giving now higher dose per kg. However, I'm giving it less frequently. Again, bring it back to the thought of the kidney development. Vital signs, and we talked about ADME as well principles, which I will highlight in the next few slides. So let's take it one at a time, like start with the absorption. Okay. Again, these are all factors might affect your drug concentration, drug dosing for those children. For the GI tract, for example, we know that gastric pH for term infants is around 6 and 8. Again, higher. On premature infants also is even higher. That might affect or delay or incomplete drug absorption for some medications, like a phenobarb, phenytoin. In addition, the increased gastric emptying time stays longer in the gut, right? And then that might affect your bioavailability, making your bioavailability of the drug is higher. IM absorption. Neonates have decreased rate and extent of absorption. Several factors, such as the decreased muscle blood flow, right? Higher percent of water in the muscles and decreased extent of muscular contractions. All of that, all these factors affect your IM absorption. In addition to the percutaneous absorption, subcut, they might be unpredictable. How many of us give desmopressin very small dose and you see like a huge change in sodium levels? So the factors for the percutaneous absorption would be the epidermis barely present by the 34 weeks gestational age. Straitened corneum in the skin, underdeveloped for those patients, might affect absorption. Also, the increased skin hydration. Distribution, infant children have a higher amount of water to lipid ratio in their extracellular compartments. This medication that poses a greater degree of lipophilicity, like the lipids, right, might not be affected, but however, the hydrophilic drugs might be affected, such as, let's say, aminoglycosides and others. Protein binding, this is a big factor. This is a big factor that also leads to contraindication for some of the drugs, giving us the cutoff of those agents. So decreased plasma protein binding and binding capacity of proteins. You know, some of the medications are maybe 50, 60, right, bound to protein, 60%. That increase in the volume distribution and the amount of free drug circulating in the body will be higher, giving you more side effects. You think about ceftriaxone, Bactrim, these agents when they are also displacing bilirubin from albumin and causing kernicterus. Metabolism, some examples like oxidations, term infants activity of cytochrome P450 enzymes is about 50%, and then by 1 year old postnatal age activity increases up to 5 times. So we see them as rapid metabolizers sometimes. Some of the drugs will be converted fast either to active or inactive metabolite, depends on the drug. And we have examples like phenobarb and theophylline. So question would be, why acetaminophen is not toxic in neonates? What do you think? All goes back to metabolism here, because when we think about adults, we have the sulfation methylation to metabolize it. However, it's depleted. So what's the alternative for neonates? They're using the glucuronide and glycine conjugation, which is, the opposite, sorry. At birth, they're using the sulfation and methylation pathway, which is developed to metabolize acetaminophen. However, in adults, the glucuronide glycine conjugation, which is immature and reduced at birth. All right, the last part of the ADME is the excretion. We talk about glomerular filtration rate, calculating the creatinine clearance, estimating kidney function. Again, to dose and adjust medications might be challenging sometimes for those specific populations, especially at the first few days, few weeks of life. Serum creatinine concentration, we might all know that when you check it for a neonate in the first few days of life, might be elevated, right? Which is reflecting the maternal concentration of the mother, right? And at 6 months might reach the adult value, and the preterm infants have diminished GFR due to immature glomeruli, proximal tubules, and reduced blood flow. Therefore, medications can be affected by this decreased GFR, like aminoglycosides, ampicillin, endomethacin. All of these agents affected by the patient's serum creatinine. That's why the dosing reference for those patients will be different in terms of frequency, when we see gentamicin given once daily instead of Q8 hours. Tubular secretion reabsorption, also another factor that might affect excretion of medications. All right, just maybe refreshment. We're using bedside Schwartz for calculating, estimating kidney functions. However, for young kiddos or those are infants, premature, we need to use different factors for calculating GFR. That's why we go with Schwartz equation. However, what do we do with neonates in the first few days of life? How can I estimate kidney function? Can I rely on those equations to estimate kidney function and adjust medications? Might be challenging, right? Because again, as I mentioned earlier, the first few days of life might be elevated, but reflecting maternal, and then might be decreased, but how would I calculate it? 5 days old, for example. So usually the trend of serum creatinine is very important, plus is calculating or measuring the urine output, what might give you a clue if there is a kidney injury or not for those patients. All right, so listing some of the medications that they have cutoff to use for pediatrics, starting with aspirin. We all hear maybe family members say baby aspirin may be marketed for kids. However, no, it's just the name, right? Misconception, misunderstanding. However, we still use it in pediatric, right? Maybe you have seen multisystem inflammatory syndrome or COVID-related. We might add high-dose aspirin, higher than adults per kg per day, right? Reaching 100. However, there is a cutoff less than 12 years old if, due to the risk of Reye syndrome when there is a concomitant viral illness like chickenpox. Tetracyclines, tigecycline, I think we all here learned about this early. It's an old contraindication for less than 8 years for the permanent discoloration of the teeth. Fluoroquinolones, less than 18, so it's all for all pediatrics. Again, defining pediatric cutoff here up to 18 once they hit 18 they're adults. I know some hospitals for admission criteria might only be up to 14 once they hit 14 admitted in the adult floors. However, I still consider those as pediatric by definition. Arthralgia, tendon rupture might be the warning. However, we might see these agents used for pediatric when we balance benefit-risk ratio. It depends on the reason for using the medication. Sulfamethoxazole, trimethoprim, 2 months. We talked about displacing bilirubin. Also benzyl alcohol toxicity. There would be a maximum we can give for neonates 100 milligram per kg per day. If you're exceeding that, you're increasing risk of gasping syndrome in neonates. Ceftriaxone, same concept of cronectras for displacing bilirubin. The cutoff is for all neonates. Also, there is another warning about it might bind to calcium, right? Affecting the absorption, forming insoluble precipitate. Again, when you think about calcium, is not only clearly added to IV fluid, you might see it
2 minutes.
hidden in some of the medications as like lactate drinkers, not be reported. Chloramphenicol, 1 year for Gray syndrome, nitrofurantoin, neonate for anemia, and other opioids for risk of respiratory depression, and 12 years old, but less than 18 if they are post-adenodectomy or tonsillectomy. Again, some hidden electrolytes you need to be aware of, like calcium content in lactate drinker, lantiplasmalide. There are also specific areas for errors when calculating for drips. You need to know the concentration, how to find out the concentration of these drips, calculating the titration rate, then dividing by the concentration. We need to know the minimum amount you can run in the smart pump infusions, 0.1. So in those who are having less than 0.1 ml per hour, you might need to decrease the concentration of the products to be able to measure it. For the sake of time, skipping question, we'll explain the concept in the next few slides. So in general, I have some considerations for weight-based dosing when I exceed sometimes adult dosing. So I put like in my back of my mind, in general, if they hit the 40 kilogram and above, I double check both pediatric and adult dosing and make sure I don't exceed the adult dosing. And some dosing might depend on other factors like the age or weight categories, like you see in dosing aminoglycosides in neonates in this table. Other areas for drug dosing consideration, milligram per kg per dose versus per day, using body surface area, GFR in calculating the doses in some drugs, combine drugs based on which component of the drug you're dosing, dosing units and administration. This is an area maybe to think of for which way to use for the babies when they're born. In general, just to make it brief, usually go with the birth weight. It depends on the institution, but in general, birth weight, and then until they reach the birth weight, I don't change it, but I measure it over a week and average. If it's more than 10%, I might adjust some of the medications for the new weight. These are for your reference, some references you can use for looking up some medication dosing. Again, some might not include everything you're looking for. Now moving to the end of the presentation, the tips and summary. Most drugs are made for adults, and if used in children, often are repackaged or diluted to be measurable at least 0.2 ml on a 1 ml syringe. Provide preservative-free products to neonates whenever possible. Provide exact doses whenever possible. Never use trailing zero, like don't say 5.0. Like we always should use preceding zero, like 0.5, 0.5. Dose in milligrams, not in mLs as possible. Provide liquids for those less than 10 years old. If no commercial liquid available, maybe other recipe can be developed in the institution. If no data, can tabs be crushed? Again, we can check resources for that. Can drug be mixed with food or applesauce or juice for taste, palatability? All right, this takes me to the conclusion of my talk today. Pediatric pharmacokinetics are different than adults. More need to be done to protect pediatric patients from harmful medication errors. Determining the appropriate dose of medications for a child requires an assessment of multi-factors. We talked about like the ADME, absorption, distribution, metabolism, excretion, patient age, weight. The appropriate dose for pediatrics is often listed as a range of weight-based doses. Again, this is a big area for error. Actually, this is the most reason for medication errors reported in the literature is the weight-based dosing for those patients. Standardization is the key and to reducing variability and decreasing risk of error. Thank you for listening and your attention.
Thank you very much, Dr. Khalid, for your informative presentation. The question will be at the end. Now we'll go to the next session, and lecture, which about from medication safety to neonatal safety in the NICU. Role of quality in improving neonatal safety. The speaker will be Dr. Adnan Hadid. Dr. Adnan is a consultant neonatologist and clinical assistant professor at King Saud University Hospital, and he's an editor of the Al-Walid Journal under the Saudi Neonatal Society. Dr. Adnan.
No, that's okay. I think I need 25 minutes to finish the lecture.
It's okay.
SNS الترتيب يطلع. SNS okay. Hopefully will be slide زي الأوفيس اللي عندكم ولا نبادل.
خلاص.
Accepted.
PowerPoint.
ثواني والله. Okay. Is the presenter working?
بس لما تحط سكين مرة واحدة
هيشتغل؟
يشتغل بس مو مرة واحدة. It's okay.
Assalamu alaikum. Good morning, جميعا. I'm quite happy because my presentation on Wednesday, because special day for our Syrian from homes. Asking a person to talk about safety in general, as if you are asking a person to talk about neonatology in one lecture, exactly. So it's totally subspecialty from quality, which is very hard to cover it in one lecture or in 1, 2, 3 days or one course. And usually the argument will be always, who will give the lecture for neonatologists or any medical doctors? Is it the physician, the doctors, or the qualification? I don't know, it's not clear, so sorry for that. So, I'll try to use laser, okay. So is it the doctor will give the doctors or qualification will give to the doctors? I think if you leave the talk to the qualification, he will spend maybe 5 hours or 25 hours rather than 5 minutes or 25 minutes. So I'm trying to do a balance between my subspecialty in neonatology and my study in quality, as I'm working in as a qualification also rather than neonatologist. I think nobody is putting hat, isn't it, in the theater? Mafi. While indeed I'm not going to go in depth too much. Regarding quality, I know that most of the people, they don't like quality. They are not involved in quality that much. And most of the people maybe hate quality because the way how it's presented to them. So most of the people putting the black hat. So arguing, resisting a lot of bad things regarding the quality. So please try to remove the black hat while we are dealing with something new, especially the quality, and try to use data hat or creative hat or whatsoever rather than black hat, please. At the end of my lecture or any lecture, it's well known that for the lecture you'll get 5 to 10% of the lecture. That's what's well known and well established. Unless you go and discuss with your colleague or your team later on, you can increase this 5% maybe to 30%. And we know that the best way to learn is to teach. So if you are teaching others, you can gain up to 90% of the topic you are talking about. My lecture, if I will name it in another name, I'll give it why lecture. So why I give it that name. Is there anybody of you using a quality tool during his daily presentation? I'm sorry, the daily round, when he's dealing with the doctor's cases, complicated cases, he's trying to lead the team. Is there any tool you are using daily? Dr. Yasser, am I right? Or, yeah, tfadal. Anything you are using or?
Yeah, we have specific guidelines in Canada, which is EPIC. I'm not sure if you heard about that or not. And so we. Okay,
I get the course. I get it with Dr. Ayman.
Very good.
He's my friend.
So the course is very specific about different areas.
So
and, yeah.
I'm sure, quite sure, that's all of you using one of the tools during your round, but you don't know that maybe the tool you are using. I'll go through all the slides. I'm just keeping in your mind that I will keep repeating why always, because really this is a tool we are using during our daily round. But how to use it, I'm going to that in that slide. We are coming to our work daily for 2 reasons. And most of us coming to work, but not all of us coming to improve our work or our quality of care we are giving to our patient. Objectives, a lot of objectives. I'm going to go through it quickly. I'm not going to name it by name. Why quality? Quality, I'm not going to give you a lot of numbers, the cost, things. It's well known for all the people that if you not apply quality, it's very costly. So no need to go for the numbers because I'm sure within 2 to 3 minutes, maybe before you leave the theater, you will forget all the numbers. But it's there. Safety or quality, honestly, when it started. So I'm trying to give the talk to the qualification. So as a physician or doctors, I'm not that aware really. I don't like to go in depth regarding the history of the things. 1999, exactly in November, Institute of Medicine, they get their report and they call it "To Err is Human." And I found that the best translation of "To Err is Human," that's كل ابن آدم خطاء. And it's part of our humanity to make mistakes. So you cannot eliminate. It's no way. 2001, 2 years later on, they gave another report. What they name it, to cross the quality chasm. So it's not only gap. We have what we call in Arabic, huwa. We have huwa, sahiqa. Very big problem between the system we are using and the system we are hoping to reach it. So it seems to be very simple issues, to err is human things, but it's what the reflection of that on the quality, on the practice. So honestly, quality or safety started very long once we start with the Hippocrates, first do no harm. This is the most important principle of safety. After that, they put 6 dimensions of quality. The most important one of them, honestly, the safety. So always when Sibahi will come to you, they will use the safety. You should match it, or the standard should be met 100%, or close to that. International Patient Safety Goal, I'm going through it quickly. There's 6 goals. I think most of you heard about it. Identify the patient, communication, medication, washing your hands, and all. I think it's well known for you. I'm not going to go through it in details because it's every one goal of them really need more than one lecture. And NHS, they put 7 steps of patient safety. I'm going to put some, or to talk about some of them in very brief. Like building a safety culture is very important. If you don't have safety culture in your institute, it's just you are wasting your time, honestly. Whatsoever your knowledge, you go very deep in inequality, it will be useless. Leading, I think something is very difficult. Promote reporting, which I think the most important problem we are facing, and we're trying to convince the people to report, and because they are looking at it as if you are punishing some person. Involving and communicate with the patients and public. That's, I think we'll go to this one in the next slide, because we decide in Saudi Neonatal Society for better communication, because we know that most of us, even Arab people, is not talking in Arabic with the parents, medical terms. We are facing a lot of problems. We don't have, honestly, maybe in the Arab world, even trusted source for information for the parents. So we decide to have like magazine or journal talking about neonatology in very simple way, in a language that could be understood by the parents. This is its first number. We start by November. That's why we focus on topics which is related to November, as you know that it's prematurity day. Even the colors, we try to give it purple. A lot of type of cultures, inequality, blaming, non-blaming, just culture. I hope that you hear about what is the just culture. I'm not going to talk about it because it's really need a lot of things. You can go to the Saudi Safety Center. You find a lot of application things and manual for how to apply, how to do the just culture. But I'm going to talk about what is our culture, how we are practicing safety culture. This is in brief a report from one of the nurses. She, by mistake, she gave the vaccine to the baby, and it was given before. It's hepatitis B. So because I'm keeping repeating, Dr. Jasem, encouraging the people in the hospital to report that it's healthy, reporting more healthy system. So she report herself that I give them medication, and she came to me asking me what is the way to prevent it in the future. The problem, this report, the OVRH, the nursing office, really, can you imagine what their decision that time? It's termination. So finally, they accept to give her final warning letter, And if it's repeated again by any mistake, you should be kicked out of the hospital. To your knowledge, that we are a just culture in our hospital. And we believe that we are doing good inequality. But if you come to the reality, really, we still right now, and most of us, I think, we are practicing blaming culture. Why culture is very important. So this flower will not be able to survive in the desert. So this is the environment. If you don't change your environment, the quality will not work at all. And that's what's happening in most of our hospitals. So again, Institute of Medicine to Err as a Human, what is the reflection on the quality of our care in practice? IHI, I think all of you hear about it. 2006, they start their project. Just imagine, not only it's 14th of June, 9 o'clock, it's very specific. This is what we call smartification of the goals. They start their campaign to prevent 100,000 deaths, preventable deaths. And within 18 months, they were able to save the life of 124,000 persons could be killed by mistake or by medication error or whatsoever. I cannot imagine really how they were able to involve, it's their goal to involve 2,000 hospitals across the US. They were able to involve 3,100 hospitals in their campaign. It's something really magic. So sometimes it's difficult to involve the same consultant, the same unit. What about neonatology? Any reflection of equality or to err as a human or to crossing the chasm or whatsoever? So we know that we have surfactant, nasal CPAP, high frequency nitric oxide, cooling, which is improving the outcome and decrease the mortality of our small babies. But we have like a plateau, 1998 till 2006, nothing is a change. So usually I'm keeping like a guess till the end, but because to shorten the time, I'll give you the answer. What happened there? 2006, same campaign in pediatrics. It was published later on. This is the key drivers. I'm not going to go there because not everything you can get it from outside. It's done in Canada or US. You cannot apply it here. Quality is not copy and paste at all. So you have your problem. You should sit, discuss, and find the solution for it. So just look at the CLABSI when they start their campaign. And look at the mean, it's decreased always, most of the time, not always. That's where we're aiming to decrease any incidence, mortality, CLABSI, FAB, the measure morbidity by 50%, but we were able to decrease it much, much less. And this is when they start to implement, and they were able to save lives of a lot of babies, more than what are expected. Again, I'm going to discuss some ideas or models of quality, so just please tolerate me. I'm talking about as a doctor, as a consultant in neonatology, not qualitation now. On Fridays, that's one of the consultants called me. It's a very simple scenario. That's, can you teach your doctor how to calculate the calcium dose? That is very simple. I mean, just open your fax and you'll find the dose there. It's very simple. No, doctor, we need special preparation to put, I don't know how many ml and how many 200 something infused. And I said, sorry, doctor. For myself, I don't know the dose, the way you are calculating that. So if I continue with her as a consultant or as a doctor neonatologist, I'm sure I will quarrel with her. Why you are blaming my fellow? Why you are doing like that? You don't give a clear order or whatsoever. But I prefer to go with her in a simple way. Doctor, how you write the order in the file? Sorry, we give it in verbal order. That's okay. Do you know, doctor, that it's high alert medication and a mistake in that things it can kill the baby even. I'm sorry, doctor, we were busy and it's okay. Doctor, do you have a protocol to give the medication the way you are giving to me, to dilute and to prepare? No. Sorry, did you come and discuss with the team? Did you talk with the doctors that you are missing the protocol, missing a lot of things? No. So then why you are blaming our doctor? So you should blame whom? You should blame the system. We don't have protocol. We are giving verbal order for very serious issue. So honestly, the system itself, we have a critical problem in the system. First model as a qualitation, I'm going to tell you about what we call Swiss cheese model, that the event will not reach the person because of simple mistake. It's no way. You have a lot of barriers. Unless you have the holes, this is what we call the active problem. Unless you have it at the same level, the incidence or the error will not reach the patient. So, okay, I don't have protocol. I give verbal order. The nurse
5 minutes.
double check.
5 minutes.
We'll find another 2 slides. Okay, so in brief, if you have good system and you close the hole, so you will be able to prevent. So just simply think in medication error or any problem that you have a system, you need to fix it, not blaming the person, not even blaming the system, just try to fix the system. This review, that's most of the medication errors coming from the doctors. Sorry, because I'm on call. So if you fix that, personal experience, you'll be able to fix part of the problem. The other methodology, it's the iceberg. So the error which you see, there's fatal problem. But it's hiding down a lot of problems. It's the failure of the system here. All of these things, if you did not look for it, you did not search, you'll not be able to fix it. And you'll keep repeating the same problem. The doctor did mistake, he wrote the wrong medication, but you have a lot of things you did not fix it. This is the iceberg, and you can do it at the same time, Swiss cheese with the iceberg. Root cause analysis is very important. I'm sure all of you doing root cause analysis from time to time. We are facing problem, you call qualitation, and you try to brainstorm and looking for the cause. I'm sorry to put it in this way, because just to show, this is the effect and this is the root. If you did not get the root of the problem, you'll not be able to fix it at all. So if you treat this part, it's useless. 5 whys, I'm using it daily during my round with my fellows or doctors. Unless you ask 5 whys, this baby has this problem. Why? Because it's premature. Why? Because there is surfactant deficiency. Why? Because. So unless you ask that, you'll not reach what we call it pathophysiology of the exact cause of the disease. So just it's a premature baby. It's okay, there's a lot of things to think about it to reach the root cause of the problem. And by the way, this is not only quality, it's medical education tool that you can use it with your colleagues. Everything, if you give the answer, why? So that's why the doctors ask me, it's always asking why. It's to call you like a why doctor. So try to make it simple. FEMIA, I don't know if you hear about it. So it's qualitation. I'm not going to talk about it. A lot of things. It's proactive way. This is from IHI. So there is a process, and I can sit with my colleagues to anticipate what could be the failure in this step or this step and this step, and I try to fix it before it's happened. So it's a proactive. This is much better than after the problem is there, then you can sit to discuss it. Patient safety days, a lot of things you can talk about it. The goals, you find always reporting, one of the most important goal in all the quality days or safety days. Why we are reporting? For one thing, I'm not going to near miss things. This is quality, I don't like to go in depth in. The future harm prevented. This is the reason why we are reporting. And if you call any person, just can you report that? No, I don't like to blame the others. I don't like to make a problem for him. Really, we still right now, we are facing this blaming culture. Reporting is healthy, more report is more healthy. This is our system in the hospital. Risk management, I think, is very tough for doctors to go through it. Can I have 1-2 minutes extra, please?
Try, because restricted time. Go ahead.
Okay. So, in your opinion, if you have, if you increase skin-to-skin care, what we are trying to reach in our hospital, even for critical babies. Without quality improvement projects, you would not be able to do that. So this was published in perinatology, and our perinatologist was very, I think it's very difficult to go through it in details, but just put the process, you have it. Sit with your team. Don't borrow something it's invented outside and you try to apply it. It will not fit in your system at all. You have your mistake, you have your problems, you have a lot of things. It not be fixed by Canadian or American system. So look for your problem, then try to fix it. And you can target the most important causes. This is what Pareto, the result of that one, they were able to increase more than 50%, 60, 70%. They redesign their process and test it again. This is the way how to do quality improvement project and see the benefit of that. It's helping the baby to shorten the time for skin to skin care and increase the time of the babies staying on the chest of their mother. They followed 6 Sigma green belt. It's not that difficult, while the black belt is more complicated. Honestly, that's take home message. يعني زي ما نقول الquality is not prestige anymore. So as if you need, as a doctor, you need to understand anatomy and physiology and biochemistry. You need to learn quality. There is a human, that's right, but please don't waste a good mistake. Learn from it. Quality is everyone's responsibility. It's not my responsibility as a qualification or the quality team or whatsoever. Unless all the people involved with quality, it will stay as a paperwork in the drawer, and that's what we are doing usually most of the time. If you did not build good quality culture in your hospital, you'll end by what we call, I hope that's all of you aware about, what we call second victim. It's going to affect you yourself later on. Very important, system, always look for the system. Try to fix the system. System, it will be fixed by systematic way, not by my opinion or your opinion or whatsoever. It's systematic way to fix the system, and always focus about S. S is system, systematic, and safety will be there if you work as a team, not like a group. So most of us putting 5, 6, 10%, they're not working as a team. That's group work, just because they are sitting with each other. So responsibility for all of us, and the team together, everyone achieve more. Thank you very much.
Thank you, Dr. Adnan, for your presentation. And now we'll go to the last lecture in this morning's session. Will be about SNS research plan. Our speaker will be Dr. Sajjad Al-Rahman. Dr. Sajjad is a professor of pediatric consultant neonatologist at Sulaiman Al-Habib Hospital, Qasim. He is an associate editor of the Journal of Clinical Neonatology, and he's now directing the medical research in the Saudi Neonatal Society. Dr. Sajjad.
Assalamu alaikum. Thank you very much, the chair and the organizing committee, for allowing me to present this very important subject. In fact, we started this with the initiative and the vision of Professor Abdurrahman Al-Nimri and Dr. Jasmine Abris. They started thinking about starting research from the platform of Saudi Neonatal Society. And they asked me to take the responsibility to initiate some plan, which I happily accepted. And today's presentation is only to present our thoughts with you. And we just want your opinion and your input, your guidance, and your leadership to come and participate in it and advise us, is this the right thing we are thinking about, or it can be made better than what we are already thinking. Research and development at the national level, which is what the SNS is thinking about. These research and development plans are a hallmark of developed world countries, and you all have worked in many developed world countries and done your fellowships and trainings and service. And the data which comes out of these research and development activities, it guides the growth and development of the nation as a whole at various levels in various fields and at various steps. So we decided to streamline the objectives. What SNS research and development plan should be aimed at? So we had three objectives in our mind. One is to develop a national neonatal perinatal research strategy and plan of action, which I'm just going to present to you. The second is to provide training in research methodology. And the third is to launch national neonatal perinatal research projects. Many of our colleagues are doing excellent job and excellent research at the institutional level, and some are doing it in a collaborative way as well. But we do not have something at the national level, as it happens in many developed world countries. So first thing we did is to start establishing an office for the research. And we did a little bit of setup in the Saudi Commission's setup with the existing resources, with some secretarial support and coordination and communication. The second thing which we are thinking to do is to establish a national neonatal perinatal database or a registry. And this is very important. We have been discussing this with our senior colleagues like Professor Saada Saidi and others who have done a lot of work in the past on this one. But this thought could not be materialized, and it has not reached a level where we can say that we do have a reliable national database which can form the basis of our research and planning for improving perinatal and neonatal care. So we need to have this database and registry. The second thing is that this kind of database registries exist everywhere, and we know all these famous registries in well-developed countries like the NICHD registry, Europeristat project, which is a 26 countries conglomerate in Europe with one registry, and the registries in Canada and the Australia. In the Middle East, we also have one very good registry in Lebanon. That's a National Collaborative Perinatal Neonatal Network by Dr. Khalid Yunus, and it's working very well and providing a lot of data and a lot of publications coming out of it. And when I was in Qatar, we established this Qatar's National Perinatal Registry, which we called Q-PeriReg. And that was my experience, which I wanted to share here and see how can we do that. Qatar basically is geographically a small country with small population, a very consolidated place. So we were very successful in establishing a national neonatal perinatal registry, which we did in 2010. It was a totally electronic database, and we prepared a custom-made software from a company in UK called eDendrite. And it was a huge registry because there were 600 data points for each patient, each mother-baby pair. And the data was collected daily, and there was within the registry there was an inbuilt statistical system which could help you analyze and give you the data in the analyzed form for publication. One of the big problems and a big challenge which we face with every registry is the safety of data. Though the registries are not supposed to be naming the patient individually, it is a collective data, but still the data has to be safe. So we made it safe through the electronic means, hosting the data, web server safety, and everything which would possibly be done, protecting it with the passwords, account control, system timeout, data audit, and all these things were built in the system. And then from this system, we started generating data and publishing it in various journals. And it was very easy. And we could publish the total number of deliveries in the country, in each hospital, total number of babies born, total number of stillbirths in the country, number of live birth babies and at various gestations, and the preterm babies and their profile, And then we were also able to do some historical work. We went back into the database of Qatar Statistical Authority as well as the database of the Hamad Medical Corporation back as 1975. And then we were able to generate the graphs as how there has been an improvement in that country in its neonatal mortality rate, early neonatal mortality rate, late neonatal mortality rate, and perinatal mortality rate. And this shows how the system has progressed successfully. And this was quite reliable data because the control was very good and it was doable. So what happened is that this Q-PERI became a reliable resource of national development, research containing both research and administrative data, and a lot of people could do their research, including the trainees and the fellows. We also wrote, published a number of papers, and we wrote 2 books on neonatal perinatal mortality. Most of the data was coming from Qatar, and this is one of the book which I published on neonatal and perinatal mortality in 2015 with global challenges, risk factors, and interventions, but with a number of contributions from colleagues from other countries as well. So can we go ahead and have a Saudi neonatal perinatal registry? That's a big challenge. And that's the thought I wanted to share with you. And that is where we need your advice, your input, and your leadership to come forward. Well, Saudi Arabia is geographically a very big country. It is a diverse type of place. It's not a small country like Qatar. And the population is widespread in many areas. And what we need is a reliable data collection. The data which we should have in the registry must be collected in a reliable way. And the big question is, who is going to fund this project? We do have a lot of good opportunities. MashaAllah, we have a large number of very good healthcare institutions in Saudi Arabia, very enviable and very well organized. And we have a large number of well-trained neonatologists. All of you are here and you have done a lot of work, very well established and well-known people here. So we don't have a deficiency of manpower resource as researchers, and we don't have a deficiency of institutions. And then we have a number of good neonatal fellowship programs running throughout the country. So a lot of fellows are available and they are bound to do research as a part of their training. So there is an opportunity that we can utilize them. And you can train them as well. And there is a very good communication system which needs more improvement to work together. So for a Saudi neonatal perinatal registry, our proposed plan is that let's take a small start. Instead of taking a big start and not achieving anything, it is better to take a small start. So instead of having a software, we can start from just Excel-based data collection. And instead of having 600 data points, which we had in Qatar, we can have a small number of database points, 30, 40, which are easily doable, collectible. And as we go forward and we become more confident, we can expand the database and we can have more and more data. We did ask for a part-time statistician, and many thanks to Saudi Neonatal Society. They did agree with it. And we will need country-wide data collection centers. So your suggestions, advice, and expert opinions are welcome. We are here to move forward and take everybody along. The second thing which we were thinking in the research plan was a half-day seminar on priorities in research in Middle East. Well, we want to do research, but what is our priority? Should it be perinatal epidemiology? Should we have some kind of multi-center research projects? MRCTs, or what is better for us at this stage? Of course, we would like to do everything, but we have to prioritize. Let's post first thing first, doable thing first, and then we slowly, gradually go up and do everything. So we wanted to have a Zoom-based seminar, which we did organize, but we have not yet been able to implement it. Probably in 2023 we'll be able to do this. And we want to call international research experts, and I was talking to Dr. Yasser Sayed yesterday about it, and we need their advice and input as to how we should move forward on it. Then we wanted to have some training sessions at national level in research methodology, which most of our fellows and junior colleagues do need. And we can do that from the SNS platform. And our young colleagues must know how to write a research plan, how to apply for a research grant, how to do statistical analysis, how to publish the papers, and how to follow all kinds of research ethics and IRB code of conduct. We also thought that probably we should be able to launch at least 2 well-funded national multi-center research MRCTs. We don't have any specific idea with us, but of course everybody has got his interest, and some colleagues are better in one field than the others. Some are more interested in ventilation, others are more interested in nutrition, and so on and so forth. So we want to welcome any ideas, anything which can be done at the national level and which we all can contribute to and do it easily within our resources, within our circumstances, and make it a success. And also funding ideas are also welcome. And I've been discussing with this Dr. Ali Al-Mudir, and we decided to go and contact the KCAST. Just one funding resource, but there could be many other funding resources. And we can work and collaborate with other colleagues in the region, and maybe we can find some research needs some funding and definite funding and a commitment. One reason which we were successful in Qatar, because Qatar has got one very good research funding body, QNRF, Qatar National Research Fund, and that gives a lot of definite funds, and it promotes research, so that money makes the mayor go. So we need to have money to go ahead. I just also wanted to share that we do have our own experience of participating in international MRCTs, and as well as having our own MRCTs. And when I was in Qatar, we participated in 2 big projects, Twin Birth Study and NIPPV trial, which are the projects funded by the Canadian Health Research. And then we had our own MRCT MACUL study. This Twin Birth Study was international MRCT from Women's College Hospital in Canada. And we participated in it, and luckily Qatar became one of the best recruitment center, because we had one big hospital with 12,000 deliveries a year, and we had a very big NICU, 105 bed NICU, and there are patients everywhere. So since we were dedicated to the work, so we could contribute that. So we became the best recruitment center.
Dr. Sajjad, 1 minute.
Yes, that's what, inshallah. Then NIPPV trial, we were the same, and we participated in it. And this was MACUL study, our own trial, which we initiated from Qatar. And for that, again, Qatar provided, the institution provided us 600 million riyals as a 3 years project to be done. And we recruited many centers from the region. We trained the staff, and this was the project where we were comparing hypothermia alone with hypothermia plus magnesium sulfate. And these are our recruitment centers, and the biggest number of patients came from Turkey, very good friends and colleagues there. And thanks to Dr. Jassim and Abaris, and we also had some patients from Saudi Arabia. He was one of our participating center. This is the paper we published on the feasibility of this study. So the plan is, let's take our first small steps. This is what I'm here to give the message. And we are here and we are open. There's WhatsApp number, it's my personal WhatsApp number and mobile number. So please do send me the message or do send it to SNS, and we are open and welcoming to everyone for your suggestions. So the greatest pleasure in life is doing what people say you can't do it. But inshallah, we will do it. Future is not a gift, it is an achievement. Thank you very much.
Thank you, Dr. Sajjad, very much for your initiative. Now we'll have 15 minutes for a question and answer. I would like to ask our respected speaker to be in the audience, please. Dr. Sajjad, let's see. It is.
Very big, royal size chairs.
Yeah, I thought I can't even.
Not good for small people like us.
Okay, so any question for the speaker of the first session today? Dr. Yasser?
Yeah, thank you for accepting my question. So I have a comment and a question to Dr. Adnan about the quality, which is actually the future in practice and improving our quality of daily practice in intensive care all over the world. So I would just like explain a little bit more about our experience in Canada and EPIC. For the last few years, we moved from considering quality as a science, as courses that you can attend and and practice in our unit. And we created specific groups, and these specific groups, we got very successful models that can be reproducible in other countries, including Saudi Arabia. So we created the specific national groups in certain domains, including infection control, hemodynamics, brain health, lung health, and so on. And the key of success of that, the teamwork, that should include not only physicians, nursing staff. They are very important to be included as a respiratory therapist. We meet actually in almost monthly basis as a national group, and also in the local group in each center. And we have a very clear report about our progress in each domain. And I'm actually a member in the 3 domains, specific domains in EPIC, and I'm a facilitator in the national EPIC courses. Last week we had a meeting with Dr. Khalid Aziz and the team, and we discussed that we can have outreach program, that we can communicate with other associations all over the world, and proceed not only from educating quality as science to have specific projects specific to certain issues in certain countries, including Middle East countries. So we are like happy to collaborate with the Saudi society and progress forward for that.
Shukran jazilan, Dr. Yasser. Thank you very much. I think Prof. Nimri remembered that we faced a problem before in doing this course in Saudi Arabia, the EPIC course. That's I tried to implement in the hospital, because in our hospital we are using focus PDSA, just because it's very simple and it's not that difficult. And to implement any methodology, I think it's not simple, as you mentioned, because all the people, once you have a team, let's say a team to decrease the FAB. So most of the people believe like a study or any, you are preparing for any research, just you have 3, 4 doctors, they are working together. Quality is more difficult and more complicated and time consuming. It will take sometimes years to achieve what you need to achieve really. So to have your team, you should educate the nurses, the RTs, doctors, all the people involved really in that problem, the stakeholders of the problem. So to be able to convince all the people to work at the same time together, I think we need time for that. It's not, I mean, that the change is not going to happen within day and night. It's going to take years. So we started in our hospital. Dr. Dassem also is part of the team. We are trying to make like a curriculum for mainly residents and fellows, and we are trying to spread it. Maybe consultant you'll find a lot of resistance, and this is for a lot of reasons. But at least we started not only to tell the people that the quality is good. So we are trying to educate them, because I think the most important barrier, because they are not aware about the importance of the quality, how to do it. If you told them that the quality improvement project is very important, decrease IVH things whatsoever, but they don't know how to do it. This is a very big problem. If the doctor, they are aware about it, but the nurse is not aware, they don't know how to do it. So you should educate a lot of people. You should have support from the hospital or the institute you are working there, then you will be able to do it. So, I mean, like a simple course we discussed with Dr. Ayman Abu Mahram. We were able to do it online in Syria, but we failed to do it in Saudi Arabia because of the cost. we did not find any person to support us, but Prof. Nimri, he promised to support me in that. Shukran jazeelan.
We have one more question before you. Go ahead, Doctor. The mic, use the mic, please. On. In the middle. No. Yes. Okay.
Which one? Thank you very much. I'm Dr. Asim from the MCH Hail, consultant neonatologist at MCH. Simple question to Dr. Khalid about the flexibility of medications. For example, the water-soluble medications, if I just write the dose and to the nearest round figure, for example, this baby is 3.2 kg and 3.1 kg, and the dose is 50 milligram per kg, ampicillin, for example. If I give 150, pharmacist will call me, doctor, your dose is wrong, it's so and so and so and so. And the nurse sometimes read the new facts and tell the doctor the correct dose is so and so and so. What do you think about this? Because sometimes the reference which you give, the new facts and the BNF, they give different doses. Great difference. I depend mainly on new facts, but sometimes I go to BNF, I find differences in the doses. What do you think, Dr. Khalid?
Thank you, Dr. Hassan, for the question. Yeah, I totally agree with you, and I have faced this recently. For example, with dosing genomycin for babies, giving some reference give you 4 per kg once daily, the other give you 5 per kg Q24 hours. So this makes also a difference. So what I would highly recommend, we try to go with our formulary reference in the hospital or the institution they're relying on for checking the doses for pharmacy and physicians and nurses as well. If it's not available, then I move it to the next step. And I try to have this, if it's not available in the formulary, and check another reference that's not handy for other pharmacists in the front line of verifying orders, have a copy or provide it to them so they don't have to go back to the doctor questioning the dose, because they won't be able to access all the references at once. All that they check, they're going to check what they have as a formulary. But again, other doses, BNF, sick kids, new facts, if they don't have access to it, I will have to provide this reference to them so they can proceed with the dose, if that answers your question.
Thank you.
Yeah, but that's a common area for conflict between pharmacy and physician nurses when prescribing doses for those population. Thank you.
Okay, next, Dr. Namri. And then.
شكرا للسبيكرز كلهم. أنا will say it in Arabic. Quality research من المواضيع اللي تثير المواجع. أنا ما نبغى نثير مواجع الناس. لكن what I will get from this conference to recommend to start. And to start, you need to have a backbone. And unfortunately, we are at the end of our board directory. Maybe 1 month you have to go to another institute. So get the backbone, continue with us. Adnan, Prof. Sajjad, continue with us. And once we get the backbone for you, we'll solve all this obstacle بإذن الله تعالى. My question for Nesreen. Nesreen, we agree with you, we agree with Adnan, quality is good, it will improve, especially the immediate outcome. But is there any cost-effective study to tell me about the long-term outcomes? That if I apply all this quality, that will improve my preterm babies' quality of life, as we improve the quality of care. Thank you.
Both of you. Can comment.
Okay, thank you, Prof. So as you know, that's what we call quality improvement projects, and every project, by definition, it has time to start and time to end. So once we are saying 18 months, that means 18 months is done, gone. So after that, we monitor. That's during the quality improvement projects, we are not fixing a problem, we are fixing the system. So if you fix the system, that means if it's working toward improvement, that's improvement should persist. And this is a very big challenge for any project to test the improvement after they stop the project. So it's still there's improvement, it's great, it's part of the project. But if it's back to high rate of IVH things, that's they did, honestly, they did nothing, just show that I did project and I improved the quality within 2 years, 3 years, then all the things is collapse. So unless you fix the system, you'll not be able to achieve persistent improvement. Shukran.
Okay. You want to comment, Dr. Nesreen? Is it?
Okay, for the cost effective, I think yes, yani, the aim of the quality improvement is to improve the outcome as well, to achieve the create culture of the improvement, patient and as well the patient. Now that we are caring about the patient experience, and we achieve all these yani, with the least cost possible to the system. And if we are trying to do the see and we'll see the improvement, might we yani, will get yani, cost effective.
We have a question from the virtual group. Can you give us the question from the virtual? Dr. Heidi. Shakil, can you put the mic? She said she's still quick. The mic, please, for the one from the virtual. Got it to. She want to say it. She want to comment. طيب, while that, we can take a question for Dr. Zahra first. Dr. Zahra.
Assalamu alaikum. Thank you for all the speakers for this session. My question is to Dr. Khalid Taher. Always, it's not always, but a lot of times we are facing that we are using medication that's out of label or even contraindicated. Like, for example, I have a baby who's having an organism that's only sensitive to trimethoprim. And my colleague in the ID consultant, she insists on using on that, and she sent me an article about a case report similar to my patients and how they use the trimethoprim. So my question is, what your recommendation in such a situation?
Thank you, Doctor, for the question. So these happen from time to time, and it depends on the medication. But going to your example, talking about Bactrim, I would think about the reason for the contraindication, right? So when you think about bilirubin displacement and having high bilirubin causing kernicterus, and I have no other options, I run out of options, what available in the institution, what I can use, susceptibility results. So I would balance benefit-risk ratio, and I might go with using the medication, but thinking about the reason for contraindication, I know now what to monitor while using it. So I will keep an eye on the direct bilirubin level, keep an eye on the patient's symptoms of having kernicterus, and then I will proceed with using the medication. It might happen also with other medications, like, for example, using fluoroquinolones. I see it a lot in pediatric population. If you look into the contraindication, it's all pediatric population. But think about cystic fibrosis patient having Pseudomonas admitted to the intensive care unit with severe infection complications. So I would look into the benefit risk, and then I would use it with monitoring the patient.
But what about the dose?
I would go with the lowest dose possible in the range, if we have the range, and then I will keep monitoring the level I want to monitor to look for the side effect anticipated. But yeah, I mean, we have faced some, and I haven't seen it much in here in my practice in Saudi, but I have seen it in Oklahoma, where I did my residency, where we used it and we monitored for bilirubin. I remember it was Bactrim or ceftriaxone, but one of them, and then we monitored the patient for high bilirubin.
Okay, question for Dr. Saad first.
I would like to thank the speaker. I think it's a very important session. And, you know, the Saudi neonatal network, it's a dream for all of us. Unfortunately, there are briefest trials and started about 17 years back. and other tribes after that. And unfortunately, there is a lot of obstacle, but I think it's the time now to cooperate together and to start. I remember in 2005 to 2008, you know, the Australia-New Zealand network, which is free of charge, and we in the society start to adopt it, and with the help of one of our colleagues, a neonatologist, Dr. Fahd Al-Harbi, even he went by himself to different centers in Saudi Arabia to explain how to use it. It's a very strong one. But unfortunately, there was some obstacle in some center. For example, some center, they don't have somebody assigned to enter the data. You cannot leave it to the resident and the assistant and the specialist because they have other things to do. This is one. There is another trial also from the society itself, no, from Ministry of Health with CNN, Canadian United Network. And they are really very cooperative and it's not costly. They just request that you have assigned a person for each center to enter the data. And in the committee of advisory committee for improvement in neonatal care, Ministry of Health, we adopted it. We had a lot of help and support from some of our colleagues in Ministry of Health. We had a problem with the legal issue that if there is any dispute, you go to a Canadian system or you go to a Saudi system. So the lawyer gave us a difficulty in this. Then there was a solution that, you know, intermediate party like company in the middle to take care of this, but this is also costly. So I think the time now to have our own, and we need some support, financial support, for example. If each center assign 1 or 2 persons to enter the data, we'll assign the database. And I think, I know, in the start, there will be a lot of difficulty. But let us start. Thank you.
Go ahead.
Yeah, thank you very much, Professor Saad. I think this is exactly what we are saying now. This is the time to start. And let's get together and move on. And we can have our own database, inshallah. Thank you very much.
So let me ask the question from Dr. Heidi. So she writes, thank you to all the speakers. Dr. Sajjad spoke to me 2 to 3 years ago about this, and I told him about the challenges. We are on the map soccer now, but we are not on the map when it's come to neonatology. The biggest problem is we have a different sector, and we cannot exclude private hospital from governmental hospital because that will reflect huge selection bias. The decision should come from Ministry of Health. Single center or 2 or 3 cooperating centers will never put the Saudi on the map. We have to have the order from Ministry of Health when it's come from there, every hospital will obey.
Yeah, I think, thank you very much. I did speak with Dr. Heidi quite a few times, and she has been very helpful and supportive, and I agree with her comments. I think this is the time to put Saudi Arabia on the world map of neonatology, as we have put it on the FIFA map as well. So this is time to do it, and inshallah we'll do it.
I totally really agree with the neonatology. I mean, starting Ministry of Health, we have a lot of program like life-saving program. It's an excellent, and the big bulk of the hospital, I mean the organization for health sector is coming from Ministry of Health. So if the Saudi Neonatal Society approach like a big institute like Ministry of Health, and in such a project, and also involving the Saudi Institution for Health Research too. So including these 2 big institutes will maybe get us back to the map, or starting us putting in the map.
Yeah, I think I did discuss this with Dr. Ali Al-Mudir, and hopefully with his presence in Riyadh, we will be able to move forward with that.
The last question, Dr. Atallah.
We have some experience in Tabuk regarding using database. We start to use it at the beginning of this year, is 2022, in January. We establish an Excel database. This Excel database is a little bit advanced. We use Visual Basic for application as a program. We build, a sheet like, and we start with almost maybe 130 columns to be filled. We get to extract, some important information with little, actually, not much. Like, for example, neonatal deaths, like neonatal hypothermia on admission, and a lot of data through this Excel sheet. A little bit advanced, but we can share you with this Excel, and we can help you also in our experience.
Yeah, thank you very much. That will be great help. I look forward to that. Thank you very much. Appreciate it.
I know there is a lot of question, but because of the time, you can ask our respective speaker later. So we'll give you a 25 break, and we'll come for the next session. And for the moderator and the speaker, the lounge will be in the second floor, right from the hall. Thank you very much for you, and thank you for our speaker. Excellent session. Thank you very much.